Hi friends, morning. Welcome to Advanced Cell Webinar Series. This is Dr. Lipi, is the Vice President and Technical Director for Advanced Cell. Today we have invited Dr. Puri. Dr. Deepak Puri is a Director of Cardiovascular Surgery at Max Super Specialty Hospital, Mohali, Punjab. And he's also a global chairman for CARDIOMERSION. I believe you must aware of CARDIOMERSION is a global group of people promoting integrated approach to comprehensive cardiac care, which is started by Dr. Deepak Puri in 2011. He's also a visiting professor at several international conferences, which is held in the United States and Southeast Asia as well. His bold initiative in regenerative medicine for usage of stem cell in chronic heart failure would bridge the basic science, understanding the stem cell action with bedside treatment strategy for patients. It also helps patients suffering from cardiovascular disease by improving the treatment options and even reversing the effects of disease or damage to the heart. So I welcome Dr. Deepak today, and he will be speaking about the management of heart failure during COVID-19 pandemic and role of regenerative medicine. So this seminar will gain the broader knowledge of cardiovascular system and how the cardiovascular system is affected by COVID-19 and how it is managed with the clinical challenges, and what's the role of regenerative therapy in this management of COVID-19 patients with the and role of stem cell in heart failure. So I would request Dr. Deepak for his valuable speech to start, and we'll take your questions and after his speech, or you can text during the webinar. So Dr. Deepak, please start your lecture. Thank you.
Good morning, everybody, and thank you for giving me this opportunity to be here today among you. So today I'll be talking about the management of heart failure, and especially in the era of COVID-19, and about the current role of regenerative therapy in the management of heart failure. So as you all know that heart failure has created a great global burden, and most of the heart failure patients, they are actually residing in Asia, and especially India has got a very high burden of heart failure patients. So as you all know that cardiovascular disease itself is responsible for around 20 million deaths every year, and a major chunk of these deaths are because of heart failure. So if you see a slide here, it has shown that although the volume of heart failure patient is quite less among the European and American countries compared to Asia, but still the majority of cardiac transplants, they are conducted in either Europe or in North America. So this shows that the heart failure patients in Asia as well as Indian continent, they have got a lot of challenges because of the less treatment options, because a heart transplant is the main choice procedure for these heart failure patients, but it is not available to everyone, mainly because of the paucity of the donor hearts as well as the technical expertise and the logistics that are involved in conducting the transplant program. So here I will first tell you something about the special features of Indian heart failure patients. The major chunk of the heart failure patients in India are because of the coronary artery disease and the ischemic heart failure, and others are because of hypertension, diabetes, and because of obesity. And now we have an added group of patients who are getting heart failure because of COVID-19 pandemic. So here the special features of heart failure patients in India that create a major challenge are because of the difference between the global and the Indian population. So if we see the global population, the mean age of the patients is 73 years, whereas the Indian population, it is 53 years. So they are 20 years younger in India. And in the in-hospital deaths are 3.8% in global population, whereas in India it is 30.8. So that is 10 times more in Indian population. And the post-discharge mortality also is 8.6 in global population, whereas it is 26% in the Indian population. So the Indian patients are much younger. They have a higher mortality both in hospital as well as after discharge. So the major group of patients who get heart failure are because of the coronary artery disease, and especially after acute heart attack. So after a heart attack, when the artery is blocked, so it is a very emergency situation, and the patient has to be rushed to the hospital because each minute the muscle is dying. So every minute of delay in the first 3 hours is reducing the survival by 10 days. So the saying is that time is muscle and muscle is time. So the patient has to be rushed to the hospital immediately. And so in most of the Western countries, like the patient reaches the hospital well within the first hour, and the door to balloon time, that is the time from the patient's door, the ambulance carries the patient to the hospital and patient is wheeled into the cath lab and angioplasty is done. So that time should be less than 1 hour. In most of the hospital, it is even less than 30 minutes. Even in India, in the good centers in major cities, the door to balloon time is well within this 1 hour period. This is the golden hour, and it is a quality indicator for a good hospital to give the angioplasty service within 1 hour of onset of the acute MI. However, many patients are residing in a far off places, and it takes more than 1 hour. It takes several hours for them to reach the nearest cardiac center. So in those patients where it will take long time, if you transfer the patient, many patients, they may die on the transit. So therefore, it is recommended that instead of immediately transferring them, it is better to thrombolize them. And especially nowadays, after the onset of COVID, because of the several restrictions in travel and sometimes lockdowns, so the ratio of the patients who are being thrombolized is increasing now, because many of the patients are not able to reach the hospital where the cardiac facilities are available well within time. So the treatment of the patient is getting delayed. And the more the delay, the more the chances of the patient going into heart failure. So the medical management of heart failure patients has shown rapid improvement. And nowadays, guideline directed medical therapy is being practiced in all the centers. That includes various medications like ACE inhibitors, beta blockers, and ARB, MRA, and IVA. But in spite of the best treatment, the 1 year mortality is still around 23%. So therefore, these patients need something more than just the medication. So nowadays, another new drug has shown tremendous improvement in the treatment of heart failure, and that is the sacubitril valsartan combination, what we call the ARNI. And this drug has been included by the ACC, AHA, and other guidelines for the management of heart failure patients. And it has shown tremendous good results when initiated in proper time. However, in spite of this, we still have to revascularize the patient at the earliest possible. And it has been seen that in multivessel disease, percutaneous intervention is not the best choice, and most of the patients, they require coronary bypass. We usually conduct this bypass as soon as possible when the patient reaches us. And now it is in the guidelines of most of the societies that coronary artery bypass is the treatment of choice for revascularization of these patients vessel disease, especially if the patient they are having diabetes and if the patient are having heart failure. So ventricular function, and because once we revascularize the patient, however, if we have to operate these patients on beating heart, more skill is required, and these patients are more sick. So only those patients who are well experienced of pump surgeons, they are able to conduct the surgeries, and the results are very good. And we have seen that there is a tremendous improvement of the left ventricular function. The viable hibernating myocardium is there. So here we see that in this group of patients with heart failure, There's a group of patients who may even go into cardiogenic shock, and these patients, they need immediate vascularization, otherwise they are going to die. And if we do the revascularization when within the time, then less the time between the onset of the MI and the revascularization, the better the outcome. And we have seen that usually the patients, they start improving after initial 48 and 72 hours, because initially there's some element of stunning which recovers slowly within 72 hours, and after that it continues to improve, and the stunned myocardium fully recovers within 3 months. And the hibernating myocardium, it takes 12 to 14 months for complete recovery. And when we repeat the echocardiography after 3 months and after 1 year, we find that those patients who are having an ejection fraction of even as low as 15 to 20%, they many times they improve to somewhere between 40 to 45, 50%, even above 50% within 1 year time. You can see this is the condition of the heart. The patient has had a massive myocardial infarction, and this is the left ventricle. And you can see that it is hardly moving at all. And here you can see right ventricle is the muscle which is contracting here, while the left ventricle is almost standstill. And here we operate the patient on beating heart, and here you can see the stabilizer which we use to stabilize. So it has to be kept away from the infarcted area, otherwise we can even witness a rupture of the myocardium, because it is very friable. And we quickly revascularize the patient. And after surgery, there may be some incidents of initial stunning, and patient may sometimes have arrhythmias, which we control by medication, combination of beta blockers and myodrone. And these patients, they later gradually start showing recovery, and after 1 year they show tremendous recovery. And many patients we have operated even 15 to 20 years back who had a low ejection fraction, they are doing quite well even now. And in between those patients who are lost in follow-up, sometimes they come back to us with another fall in the ejection fraction, because they either stopped their medication or they were not properly taking their medication. So again, we have to optimize their medication so that their ejection fraction improves. So this is the category of heart failure patients who have ischemic heart failure, and this is how we treat them. So another important tool we have with us is the intra-aortic balloon pump, which helps in tiding over the acute crisis. When the patient is having cardiogenic shock and is having severe heart failure, we insert the intra-aortic balloon pump into the aorta through the femoral artery, and then this remains there for another 5 to 7 days, depending on the patient's recovery, and then it is removed. So during that time, we revascularize the patient and the heart starts improving, then we take it out. Other options that we have are is the cardiac resynchronization therapy, in which we insert the biventricular pacing, and with that we can sometimes insert the AICD also, patients who are having arrhythmias. So this helps in improving the ejection fraction and improving the heart failure of the patient. Then we have the artificial heart, various variety of ventricular assist devices and complete total artificial heart. And then the next option that has been on the forefront for more than a decade now, and various search been conducted throughout the globe, is the use of stem cell in the therapy of heart failure patients. So this has undergone various trials, and initially people used to use skeletal muscles, and later on then autologous bone marrow and adipose tissue, they were used for treatment of patients with heart failure. And it was thought that stem cell therapy holds a very promising role in the treatment of heart failure, but somehow it has not been able to come up to the expectation till now. Because although many studies have shown that it improves the ejection fraction, it improves the symptoms of the patient, the quality of life of the patient, but which type of stem cell to be used and what dose of stem cell to be used and which route of stem cell to be used is still quite debatable even now. And it was seen that the stem cells, they have a very low survival once they are injected, because most of the people, they what they were doing is that they were injecting it intravenously, and it was seen that they don't even go to the target organs, and there's no way that they can stick there. So the dwell time was very low and the survival was less than 70% of the cells used to die within 48 hours. This was because the infarcted myocardium did not have any vascularity, so the nutrition of the stem cell source was not there. So various other improvements were thought, and it was thought that needs a proper regenerative therapy in which combination of cells should be used, and cells can be cultured so that a proper dose of the cells reaches the target organ, and we can use the help of scaffolding and gene therapy so that we improve the proliferation of the stem cell and the actual result. So most of the studies, apart from intravenous, when it was found that it doesn't show much improvement, then people started using intracardiac injections the infarcted artery. The blocked artery used to be injected with the stem cells, and we used to wait for the stem cell to act, but it was not sure whether the stem cell will stick to the infarcted muscle or just they pass through the bloodstream. So it was also used for intramyocardial injection by surgeons while performing surgery. The infarcted area was injected by stem cells on the peripheries, and then it was found that there was improvement in the function of the heart, as well as there was a improvement in the angiogenesis, and the myocardial muscle proliferation also was noticed. But the main effect was because of the paracrine effect, and it was thought that paracrine effect is the main which improves the function of the myocardium. So while all this was going on, we last year in 2019 there was the onset of the COVID pandemic, and because of the COVID pandemic, there has been changes in the management of heart failure as well as the number of patients who get heart failure. So in the next part of my presentation, I will discuss changes we have seen. We saw a huge volume of heart failure patients also. This included the patients whom we had operated before, who were having bypass surgery done, and who were with us in follow-up, and many of them also contracted COVID, and many patients who were undergoing treatment for hypertension, diabetes, they were found to be at a higher risk of getting COVID, and they even had more complications. We had to formulate new policies and new techniques for dealing with these patients. So here you can see that the first peak, which just touched barely, it was below 1 lakh. Next peak, it touched more than 4 lakh population. And even in the world, there have been repeated peaks sporadically in different countries. And then we see a lag between the peak overseas, and then after few months, the peak starts rising in India. So now WHO has declared India as a endemic area for COVID. So we have now to accept that it is going to stay with us for a long time, and we have to know how to deal with this. So if we see that the COVID patients, almost 30% they don't have any symptoms, and rest of the around 56% patients, they have few symptoms, but they don't need any treatment. Only 10% of the patients, they actually need hospitalization, and out of them 5% they recover without much eventful. And after that, most of the patients, they go home and remain well, but many patients, they have been seen to stay in the ICU and require ventilatory support. Almost 5% of these patients, 5% of the patients, they have a very stormy stay during the hospital, and almost 50% of them they die. So this is a group of patients who have high incidence of heart failure. When a patient comes to us and we do the rapid test as well as the RT-PCR, and then we segregate the patient whether the patient is to be sent to a COVID ward or to be treated by us. So if a patient with heart failure comes to us, so there is a possibility that it is a primary heart failure or it may be secondary to COVID infection. So initially, it was thought that the COVID infection it affects the lungs primarily, and because of that, the patient they go into respiratory failure and pneumonias. But later, it was seen that that was not the only process. COVID affects all the organs of the body, and some patients they may not be RT-PCR positive, so these were diagnosed with the help of CT scans. So the radiological findings they become more apparent in the second week. So these patients they were diagnosed on basis as well as with the CT findings. And then some patients they develop complications because of COVID, and these include pneumothorax, pneumomediastinum, and sometimes total destruction of the lung and ARDS. So these were the patients who are more likely to also have heart failure. So it was then seen that these COVID infection can affect almost any organ of the body. And then we have to find out ways to deal with this infection, because whatever treatment options we were having, they were not sufficient to treat these patients who were in the ICU and who were deteriorating rapidly. So there were three stages of this COVID infection. First was the viral response, which used to settle within a week or so. And next was the coronary phase, in which the CT findings used to become prominent and the patient used to still recover within 2-3 weeks. And then a third stage was the post response, in which there was a severe inflammatory response, in which there was a rise in the biomarkers, and was seeing that these were the patients who had a rise in cardiac biomarkers also, and they were the patients who had the highest risk of mortality. And these patients, it was seen that they have a very stormy course, and later on also the long-term effects of these patients remain for a long time. So these patients were initially they used to have ARDS, and then they had myocarditis, and even they some patients they had a cardiac arrest, and later on they had pulmonary fibrosis, and then fibrosis of the myocardial muscles and permanent heart failure. So the role of regenerative therapy was thought during this process, and it has been seen that the mesenchymal stem cells they had a very good pro-inflammatory modulation effect. So they were thought that why we can't use them for treatment of these patients. So initially the standard guideline treatment, which included deterioration in the respiratory function of the patient and severe hypoxemia. So at the same time, in the blood vessel level, so the virus used to damage the wall of the blood vessel, causing leaking the vessels, and used to increase the tendency of thrombus formation within the vessels. And apart from that, when we talk about the heart, the virus directly causes myocarditis as well as the inflammatory response, which is quite similar to the ischemic cardiac injury. But the difference is that in ischemic cardiac injury, there's some amount of repair and regeneration that occurs, and the long-term fibrosis is limited. But because of COVID, it was seen that there was a direct progression to the long-term fibrosis. So the fibroblasts used to proliferate at a much faster pace when they were infected by the virus. So then we have to deal with both the problems, the direct invasion as well as the indirect destruction because of the cytokine storm. So both these aspects they cause heart failure, and we have to use stem cells how effectively we can prevent their entry into the cells, and how effectively we can prevent the inflammatory response. That will be seen in due course of time. And initially, the plasma therapy was started by taking plasma from those patients who have already recovered from this COVID-19. So it was thought that maybe they were having high antibody titer, and if we inject the plasma into the patients who are at risk of having COVID, or who are at risk of deteriorating because of the severe COVID infection, has been tried, but there are limitations, because many of the patients, despite severe COVID and despite recovering from COVID, they had very low titers. And even after the vaccination, we have seen that many patients, they don't develop adequate titers. So this plasma therapy has its limitations. And also there is a possibility of adverse reactions in those patients who have been injected with plasma. So then already we have vaccine, and we are trying that the whole population gets vaccinated, and it should give good immunity to the population. And because India has got a very dense population, so if we, so even during this crisis, the FDA even relaxed the recommendation for guidelines for use of stem cells and regenerative therapy, because 50% of these sick patients, they are at risk of mortality. So it is a desperate move that we should try our best to hasten the treatment of these patients, and anything that can work should be tried. So it has been seen that if we have to repair the heart muscle in heart failure, whether it is because of the ischemic injury, or because of the COVID injury, or the inflammatory response, we have to use different mechanisms, and in which we need that there should be immunomodulation, as well as the paracrine effect control the immunomodulation, and then the dead cells should be revived, and there should be regeneration, and there should be new revascularization also, formation of new blood vessels, so that the repair process can restore the function to the previous stage. So all this can be tried, and we have different sources of stem cells, and the bone marrow is the most commonly used, and there are the adipose tissue, and even we have a group of amniotic cells, embryogenic origin. We can use those also. The amniotic membrane stem cell therapy has been also being tried. We were already aware about the immunomodulation role of mesenchymal stem cells. So, but we have to use this very logically, so that it does not cause any adverse effects, and is able to improve the recovery of the patient. So it has been tried by injecting systemically the mesenchymal stem cells, and it has been shown that it has improved the um, outcome of the patient. The mortality was drastically reduced, and also the recovery was reduced, and even the markers, they were seen to reduced within a period of a week, and the effects started coming even within 3 days after injection of these cells. Apart from that, it was seen that it helped in recovery from ARDS. So the edema subsided, and recovery started very early after injection of the mesenchymal stem cells. So this has beneficial effect, because it not only improves the ARDS and the respiratory function, but at the same time it has been seen that it improves the heart failure part also. So there are actually three generations of stem cell therapy. Extracellular vesicles, they actually cause the paracrine effect. So it was thought that instead of having the cow, if we have the milk, so we can get more benefit directly from the extracellular vesicles. So there was a process in which we were studying the extraction of the extracellular vesicles, and in some way if we can inject it into the ill person, and then we can get the maximum benefit out of it. So it was also seen that we can combine the mesenchymal stem cells as well as the these extracellular vesicles, and this combined therapy can give maximum benefit to the patient. After the FDA has approved the various trials, so not only in vitro, in vivo, both category of trials are being conducted at a rapid pace, and they have gone through the phase 1 and phase 2, and even some trials have entered phase 3. So here the role of autologous stem cells as well as the embryogenic origin stem cells are being studied at a rapid pace, and the results are quite encouraging. These are the various trials that are being conducted at various places. They have shown to improve the heart failure, improve the cardiac function, and also improve the ARDS and lung functions, and improve the recovery of the patient and reduce the mortality of the patient. But there are various limitations we have seen, that because during COVID times, sometimes there are lockdowns, sometimes the patient cannot come back for follow-ups, and we have to resort to online follow-ups. So the accuracy of the trials is quite questionable, and also we have to ensure the safety of the staff also, and we have to take several precautions so that we don't become instrumental in spreading the COVID infection. So we have to conduct trials in a very guided manner, and we hope that in future some definite results they come up, and we are able to give better modalities of treatment for the heart failure patient. So in the end, I would like to thank you for the patient hearing, and this is a simple video to show how we can keep ourselves healthy and prevent heart failure.
Thank you very much, Dr. Deepak.
Thank you.
Thank you very
The
much.
summary is
So,
that prevention is the best, and we have few modalities under our armamentarium, but still a lot of research is required to get a final solution to this problem of heart failure, especially in the COVID times.
thank you very much, Dr. Deepak Puri. So it's a valuable page. I really appreciate your steps in regenerative, including the regenerative therapy as well. So, if you have any questions, please they will take the questions. Yeah, one question is here. Is it possible to regenerate cardiac tissue? Yes, it's possible with the help of stem cells. You already know that stem cells have three properties: regenerative, repair, and rejuvenating. So we can do that, but it's still in the research phase. So how much it regenerates or fully or not, it's still in debate and in research. So, but there is a possibility of regeneration of cardiac is possible. Any more questions, please? There is another question: is what will be the what is that? Can we treat COVID patients with PRP? Dr. Deepak, we can.
Actually, it was tried,
So
like we tried
it's
the
not going to
plasma
help
therapy
your
for the antibodies. PRP was tried, but till now there's no established role of PRP as such in treating stem cells. But we have more hope from mesenchymal stem cells, and even if we can get extracellular vesicles, so that will be the best. Like people, they are thinking of giving this in the form of aerosols. Like if we can give aerosols of extracellular vesicles, so they can immunomodulate in the lungs, and they can prevent the respiratory failure as well as the heart failure.
So because PRP is not having this regenerative capacity, but it's a growth factor. But stem cell has more regenerative capacity along with the exosomes. So we prefer stem cell with exosomes rather than PRP. The question, can we do with autologous stem cell with adipose tissue? Yes, we can do. which indication you are asking? Can you please let us know?
In COVID-related heart failure, we have seen that these mesenchymal stem cells, they have shown better results compared to adipose so far.
Best option is the allogeneic mesenchymal stem cells. Any more questions, please? Thank you, everyone, and Dr. Deepak Puri for your valuable speech on COVID and the heart regeneration. So thank you very much for attending.